Good afternoon. Welcome, everyone. This is Kelly Gilchrist from the ACOG District 2 office. Just wanted to say thank you all for joining us today for our presentation on managing opioid use disorder in pregnancy. Just a few housekeeping items before we get started. All the lines are being muted today during the presentation. However, you're welcome to chat in any questions you may have as we go along, and we'll have some time at the end for question and answers. We are delighted today to have both Dr. Gary and Dr. Kaufman, our OUD and Pregnancy Task Force co-chairs, presenting for us today. Dr. Leah Kaufman is the Associate Professor, Residency Program Director, and Vice Chair of the Department of OBGYN at SUNY Upstate Medical University in Syracuse. Dr. Kaufman has a long history of service to ACOG, serving on many district and national committees, including the Committee on Scientific Programs, the CREOG Education Committee, of which she is the Vice Chair, and she serves currently as the District 2 Advisory Council Secretary. Dr. Gary is currently the Director of Maternal Fetal Medicine at Stony Brook Medicine and Professor of the Department of OBGYN and Reproductive Medicine. Dr. Gary works with ACOG as an FASD champion in the effort to reduce alcohol-exposed pregnancies. Dr. Gary has set up and established a maternal opioid management program at Stony Brook for the care of women with opioid addiction during pregnancy. So with that, I will turn the presentation now over to Dr. Gary.
Thank you, Kelly, and thank you all for attending this webinar. This is the ACOG District 2 Opioid Use Disorder in Pregnancy Bundle, Part 1. So, as far as disclosures, all the faculty, the planning committee, the reviewers, and staff involved with this project have no disclosures to declare. As far as a disclaimer, that this material is only an example and not meant to be prescriptive. And this education is not exclusive to maternal opioid use disorder. The management outlined within may also be effective in helping women with other substance use disorders. And that each clinical setting has to take into account its own resources and its community in management of substance use disorders and opioid use disorder to maintain a safe patient care. Next slide. Next slide. So today, as far as our learning objectives, this is a multifaceted education and implementation tools to assist providers in care for pregnant women with opioid use disorder. We are going to encourage communication and engagement among providers across services and including the justice system. That we aim to enhance communication of opioid use disorder through use of common language and to enhance patient and family engagement through education, common language, and understanding the treatment and the processes. Next slide. So opioid use disorder and the basics. So first, physical dependence is a psychological adaptation of the body to an opioid, whatever that opioid may be. And it's defined as the development of withdrawal symptoms when you discontinue it. And that can be discontinued because you couldn't find the medication, or it's discontinued because you had an antagonist such as naloxone or pentazocine. So that's the definition of what is physical dependence. Opioid addiction is a chronic disease. The brain has a reward, a motivation, a memory, and some biochemical, neurochemical changes that relate to chronic disease with its reward and fear of the negativity. So, like all chronic diseases, addiction involves cycles. The cycles are relapse and remission. And without treatment, addiction is progressive and can result in a disability or even death. So when you look at other chronic diseases, and this is what you have to consider opioid use disorder, is no different. When we look at relapses, type 2 diabetes, hypertension, asthma, you have patients who take their medication, maybe don't take their medication, who follow their glucose, manage their asthma appropriately, and then they don't. So opioid addiction or opioid use disorder is no different. Next slide. Substance use disorder is the proper terminology, and substance use disorders occur with recurrent use of alcohol and or drugs where you become significantly impaired and you may have health problems, disabilities, or failure to maintain your responsibilities either at home or work. And alcohol use disorder, opioid use disorder, halogen use disorder, tobacco, or cannabis are all in this category. And we think of opioid use disorder, as I said before, this is a chronic problem that results in changes in the neurochemistry in the brain. But you can combine medications and have comprehensive care and recovery support to regain control and maintain a healthy lifestyle through management and support. Next slide. So there is a DSM-5 diagnostic criteria, and you can see that this is just a representation. There's actually much more involved with this when you look up this DSM-5, but you can see there's criteria for what is mild substance use disorder, moderate substance use disorder, and severe. We'll turn it over to Dr. Kaufman.
So one thing that is very important to realize with opioid use disorder, and for that matter with all substance use disorder, is to realize that these are things that can happen to anyone, and it's not safe for us to assume that we can know the face of opioid use disorder. And we'll talk in a moment about screening and making sure that screening is universal in how we define screening. But ACOG, in conjunction with the New York State Health Foundation, have slides that are up on our ACOG website on the public side, and we're going to show you at the end how you can access these slides. But just wanted to show you an example of those videos that you can link to, really showing that you can't assume what the face is of opioid use disorder and the importance of universal screening. So how did we get here? We are starting to make inroads in improving prescribing practices, but really part of the reason or the way that we got here with respect to opioid use disorder was the idea of this vital sign of pain being one of the vital signs that we were assessing, and the ever-increasing number of prescription opioids were definitely a large part of how we got here with respect to this opioid use disorder epidemic throughout the country. In 2012, providers wrote 259 million prescriptions for opioids, and what's frightening is that was more than enough for every American adult to have a bottle of pills. 20% of those with a pain-related diagnosis, acute or chronic, receive an opioid prescription, and we know that opioids definitely have a place in a role in treatment of chronic pain, patients with chronic back pain, patients with cancer and end-of-life care. There's definitely an important role, but there definitely has been an associated issue in the past of overprescription, and then you can see the concomitant increase of opioid-related deaths and treatment admissions throughout the early 2000s going into the 2010 period. Next slide. So where do pain relievers, where were they first obtained, and how does someone start with an opioid use disorder? First exposure, this slide is pretty striking. When you talk to a patient and survey patients who are currently, their drug of choice is heroin, or their drug of choice currently is fentanyl, many times their first exposure is from a prescription drug that they obtained through a friend, through a relative, and that's true 53% of the time. So more often than not, this was not a prescription that was written for them. It was a prescription that they received because they were having pain, they were having a toothache, and their family friend or grandmother had it in the medicine cabinet, and they were able to grab something out of the medicine cabinet because it was left over from a surgery that she had. And when you tease those out further, of those 53%, 83% of those prescriptions came from one physician, again, because of the volume of the opioids that were written at that time. So just speaks to the issue that we initially had a tremendous problem of overprescribing that caused this issue. something that we have to be aware of, that now we're addressing the issue of decreasing prescriptions, and as we're coming up with solutions to address the problem, we have to make sure that we're addressing the ongoing issue of the use disorder and not just the numbers of prescriptions, and we'll talk about that more as well. In New York State, the numbers of opioid-related deaths, this also associated with the increased number of prescriptions. We saw an increase in opioid-related deaths. And what's also tremendously striking is if you look at the star, New York State outside of New York City actually has a higher rate of opioid-related deaths. And this is true for neonatal abstinence syndrome as well, where you have an increase in a higher number of opioid-related deaths over the outside of New York City for the rest of New York State. So screening versus testing, this is a really important element for every team member to understand, and the importance of screening really needs to be universal, but this needs to be universal by a validated verbal tool. There are many such validated verbal tools, and we'll point again to that slide set, and we'll go through some of the validated tools, but tools such as the 4Ps plus or the 5Ps, and there's information on the ACOG website as well through the AIM tools that have been validated, that you want to use a verbal tool to speak to the patient's past history, use during pregnancy, the family history as well, because using universal drug testing, which would be urine testing, has a lot of potential false positives and false negatives, may not detect all substances, may not detect synthetic opioids, and one negative test does not rule out sporadic use. So there's a lot of issues with doing universal drug testing, which would be the biochemical test. Urine toxicology, additional limitations of urine toxicology, as we're talking about substance use disorders, there frequently are polysubstance use disorders, so you're not testing for alcohol or tobacco. There are a lot of implications, increased risk for possible child welfare involvement, and obviously with respect to the patient's parenting capabilities, the test results are not getting at or addressing in any way the patient's parenting capabilities or family's capability for supporting the baby, and often you're not taking into consideration the lab points for sensitivity. With respect to once you are screening, it's important for all practices as well as hospitals to have a plan for their next steps. So having a system such as SBIRT, screening, brief intervention, and referral to treatment is also a very important part of the assessment, but also treatment in opioid use disorder. And having all team members or many team members well-versed in performance of SBIRT, this can include physicians, nurse practitioners, many team members, physician's assistants, counselors who can start to perform that brief intervention and then get those patients referred into treatment. But it really goes hand in hand once you're doing that universal screening, that you have the next steps clearly outlined for your team. Part of the tools that have come out of the collaboration with the New York State Health Foundation, ACOG New York State, and also ACOG nationally were the obstetric care women with opioid use disorder patient safety bundle, and point out some of the tools. All of them break up the tools into readiness, recognition, and prevention as the first two elements of those tools, making sure that you have counseling tools for patients and families, making them supporting them through their questions with respect to the screening coming forward, awareness of symptoms of neonatal abstinence syndrome as you're taking them through medication-assisted therapy, the guidelines with respect to implications for child protective services and associated testing that's needed, and what options they have for medication-assisted therapy, support for offices as well when patients are starting treatment. So I wanted to point out those resources as well as practices are looking for support and resources as they're implementing order sets and training for their team members, that these resources are available on the website as well. So moving into patient and family engagement, what that looks like, it's very important to define the patient's family, and that may be defined in many different ways, her partner, her biological family, who it is that she needs, and how she defines her support system, her support network, because she's going to need a support system, creating a toolkit to assist her with understanding what her expectations are throughout the pregnancy. They're going to have many questions, and you're going to need to help her navigate these many questions. And if you're only educating the patient and not her network, her family support, you're not going to get very far effectively with her treatment. So you really need to bring in that system of support into her management throughout her pregnancy and also throughout the delivery. Questions such as what is neonatal abstinence syndrome? What are the implications? How is baby going to be assessed at the time of delivery? What is the role for Child Protective Services? How is social work and Child Protective Services going to be involved at the time of delivery? Will they be called at the time of delivery? These are all questions that they will have, and having those questions answered up front and in the antepartum setting and with the entire family team will be very important. Medication-assisted treatment and the reason for medication-assisted treatment, explaining to her as well as her family the improvement in outcomes for her as well as the decrease in neonatal abstinence syndrome for baby will also be very important elements of that family engagement. Using motivational interviewing techniques, including trauma-informed care, avoiding re-traumatization for patients. Many times these are patients who have had traumatic events that have led to their substance use disorder, will aid in the treatment of these patients, providing them written information so that they have a visual cue to be able to take back to the family if they're not present at these visits, and that they can refer back to. And again, some of the tools that you may want to give them, or the areas where they may need to use visual cues, would be with respect to the neonatal abstinence syndrome scoring tool, or also the medication-assisted treatment. Making sure that we're reducing stigma, using common language, and avoiding language that can be harmful to the patient, and using language such as drug abuser is also extremely important. And I'm going to hand things back over to Dr. Gary.
So, actually, can you go back one? I'll just say, with respect to reducing stigma, this is one of the main areas that we are focusing on right now at our own institution, trying to engage all the staff, both in the outpatient area and the inpatient area, because there are side conversations and comments that are made that may be overheard by the patient and then lead to sort of a disconnect between her and you as the provider, you being the office or the hospital. And so it is well known in medicine that language matters. We'll go to the next slide. And so we want to make sure that, as far as language goes, that we're respectful to patients and that we use appropriate words, trying not to be offensive in any way, but also be able to identify what the issues are. So instead of a patient who's an addict, I usually talk to patients as either substance use disorder, whatever if they have opioid use disorder, cannabis use disorder, or if it's the combination, as I said, substance use. And then for the newborn, when you talk about a newborn, you want to say that it was prenatal substance exposure rather than an addicted baby. And when speaking about sort of other areas related to language, in that we talk about healthy behavior versus not healthy behavior. They're not using any of the words that are on the left hand of the screen, which have gone back for years. It used to be crack babies, crackheads, etc. And these are just language that doesn't work well. And it's really been a struggle at our own institution, as I said, in trying to get our staff to understand that how you speak to patients helps engage them. And I can't say more about that other than when you said to me, like, that old guy over there, old balding guy, that's not going to work well when if not, you can't see me, but that's sort of what I look like. So when people refer to me like that, you're not going to get, so if you think about that personally, it's important in how we talk to patients. Next slide. So neonatal abstinence syndrome, used to neonatal opioid withdrawal syndrome was an older name, but this is simply the withdrawal that the baby goes through from no longer being exposed to opioids. This has been around, identified almost 120 years ago, and we have been managing it with various small amounts of opioids to the baby. But what's important is that the patient understands what is neonatal withdrawal syndrome. Also important is to make sure that the patient understands that through prenatal care, whether it's a consultation with maternal fetal medicine or pediatrician or neonatology, or whoever in the hospital may provide the patient with the best information as far as what will happen with their baby when the baby is delivered, and that the observation period will be anywhere from, say, 5 to 14 to 21 days, depending on what medication or what opioid exposure there may be. Next slide. As Dr. Kaufman said earlier, neonatal abstinence syndrome follows the death rate to opioids. As you can see very clearly, that in the non-city areas of New York State, that's those with the stars, so you exclude New York City, the neonatal abstinence syndrome rate is somewhere around 8.4, 8.5 per thousand, compared to the city, which is down at around 2 per thousand. So clearly that neonatal abstinence syndrome and opioid use, as we'll go to the next slide, when you break it down by county and you look through New York, now there's some areas that didn't report, but you see that more rural areas away from New York City have more neonatal abstinence syndrome based on the data that was provided for 2015, 2016 in that area. So this is a problem that we see around the state, and even more so in the more rural areas. Next slide. So what do we look for when we find when babies are delivered, and what is neonatal abstinence syndrome? So this is a change in the baby. The baby may have different tone, maybe a little bit on the more rigid side. Poor feeding is very common. Excessive withdrawal, they'll have vomiting. They may have a different cry, and it's a very high-pitched cry. And of course, they're very restless and have difficulty sleeping. If they have a significant withdrawal, they will have possibly a fever, diarrhea, and sometimes difficulty with breathing. I often talk to patients about it because they want to know, well, and most patients who that are utilizing or have used opioids or have opioid use disorder understand what withdrawal is. And you just tell them that the baby is withdrawing. And so the baby is doing some of the same things that that you would do if you were withdrawing. And so we're trying to manage the baby by providing comfort and appropriate support. Next slide. So in all our areas and all our hospitals and facilities that do deliveries, you really have to make sure you develop a network of providers, because this is not any one provider. So social workers, case managers, and if necessary, the legal system need to be involved with the patient and the patient's family. So you need to sort of get together and make sure that there is some way of sharing information about what patients these may be, and when a patient shows up, that we follow some sort of algorithm as far as caring for the patient, and that social work understands what, say, at our facility, we know that I tell patients you will be seen by the social worker. The social worker is going to investigate your environment, make sure that you've had your counseling, make sure that you've been attending your prenatal visits, and once that's all together, a decision will be made if that goes any further as to the CPS or Child Protective Services, if they need to get involved or not. But that Child Protective Services is not the first line. Try to explain that to the patient. Next slide. So, as I just said, the Child Abuse Prevention and Treatment Act, which is CAPTA, involves all of this. And as I just said a few seconds ago, that you're trying to involve the community, involve the patient, involve the family, to provide the best environment for the newborn, and to try and maintain counseling and care for the patient. So we'll turn sorry for my stuttering there. My computer just shut off and I just had to turn it back on. I apologize. So we'll go to the readiness and professional education. So we recognize that pregnancy is an opportunity to both identify and to engage women with opioid use disorder and try and improve maternal and neonatal outcomes. And we try to use the common language and common terminology and engage the patients to overcome their barriers for maintaining a healthy lifestyle. So medication-assisted treatment, which is either methadone or buprenorphine, buprenorphine is also known as Subutex or Suboxone, is the mainstay of management of these patients to prevent withdrawal and manage their opioid use disorder. However, your offices and you as a provider also have to understand there are patients who are just going to say no. And you have to be willing to still provide treatment for these patients when they are ready, when they want to come in for the prenatal care, although they still may be using their opioids or misusing their opioids. And you can't turn them away from care. You just continue to try to engage them until they're ready. Next slide. Make sure that everyone in the obstetric team understands what is safe opioid prescribing practices. As Dr. Kaufman had alluded earlier, especially when patients are discharged, say, after cesarean birth, that we're managing them with the correct amount of opioid to go home with, and that we're not providing an excess number of opioid prescriptions, such as Percocet or oxycodone, that may be not used by the patient or misused by the patient in the future, or end up on the we'll call it street as being sold again to other people. So we try to manage and have changed our prescribing practices. You want to look for making sure that you reduce harm, naloxone or Narcan, that can be available. There's kits available, and you can write a prescription for the patient to have a Narcan or a naloxone kit to have at home. Almost all pharmacies in New York carry that. That you maintain appropriate treatment throughout delivery and even in the postpartum period. That the pediatricians understand what the plan is and management of the newborn, and that community resources such as domestic violence shelters, the WIC system, and home visiting agencies understand who the patient is, and that you can engage them in care of the patient. So you have to clearly define what your practice approach is. And I'm going to turn this over to Dr. Kaufman.
So you want to have you have to decide as a group and a practice and have a shared understanding where things need to be to best support your community and best support your patients. Talked before about the importance of screening, but really everyone on your team needs to understand screening versus testing. Those are terms that are really used interchangeably, and we need to be very careful that everyone on your team understands that we need to be doing screening. Where is screening done? Is screening done as soon as the patient checks in? Is it the nurse who rooms the patient or the team member who rooms the patient doing that screening? Is it the provider that's seeing the patient? Is it the physician, the nurse practitioner, the nurse midwife, the PA, whomever it is that sees the patient? Is it a verbal screen, or is it a tool? Is it a tool? Are they given an electronic screen to fill out? How is that screen being done? But the practice, everyone in your practice needs to understand why it is that you're doing the screening, how you're doing the screening, and coming up with that system. So that's a really important first step to understand and map. Understanding local resources is another tremendous piece. And so knowing your next step, knowing, we mentioned SBIRT before, but how you're going to do that brief intervention and referral to treatment, knowing where your buprenorphine prescribing providers are, is also a very important piece. Maybe your practice is a practice where you're going to do the obstetric care as well as prescribe the buprenorphine, but you need to know if you're not, that you're going to do the brief intervention, and if she's ready for medication-assisted treatment, where it is that you're going to be able to send her for the buprenorphine or for the methadone, and explain to staff as well, and so that they can counsel patients and also family members about why withdrawing mom and not putting her on maintenance treatment is not recommended for either mom or for baby. So this is a picture of the practice algorithm, the philosophy that you can adopt within the practice, and then how you would then manage the patient depending on where she is, meeting her where she is, where you would take her, how you could stabilize her if she presents in acute withdrawal. But where I want to really focus on in this slide is really at the middle of the slide, where you need to focus for your practice and decide where you're going to be with respect to your practice, because there's really three ways that you can address opioid use disorder within a practice. You can provide the full range of patient care, including the prenatal care as well as the medication-assisted therapy. So you're screening, you're identifying that there's an opioid use disorder, and then you're prescribing the buprenorphine and doing that maintenance therapy throughout. You could provide the prenatal care only and continually co-manage with a medication-assisted treatment provider with a continued ongoing plan and communication back and forth between your two centers. Works very well successfully for safe care throughout the pregnancy, or once identified, you're doing the screening, but then referring her out for both the obstetric care and also for the medication-assisted therapy, so essentially discharging her from the practice, and would say probably the least optimal as far as access for patients during the pregnancy. So hopefully option 1 or 2 would be potentially feasible, but want all patients screened and then referred to care. So you need to adopt one of the 3 practice algorithms and then realize what your next step is going to be once screened. With respect additionally to practice education, making sure that all staff are aware of what patient education you have, the pamphlets with respect to the safety and importance on medication-assisted treatment, as well as what screening tool you're using at your institution. So once she is on the inpatient side, having that tool available. And slide 72, we're going to give you the link to the appendix for some resources that you can hand them, and also the available opioid treatment programs and the potential impact on the fetus, both for ongoing opioid use, as well as the importance of the treatment, as Dr. Gary mentioned, the withdrawal that the baby can go through, and the importance of the treatment. An important part of the outpatient antepartum care may be, and really something that you really may want to consider and should consider, is an outpatient visit with the pediatricians. Often you can coordinate with the neonatal ICU, one of the neonatologists, a visit so that they know what to expect. And so beyond your explaining the scoring system, whether it's the Eat, Sleep, Console or the Finnegan scoring system that your hospital is using on the inpatient side, making them an active part of that scoring system and the awareness of what to expect, you may additionally be able to arrange a visit with a neonatologist so that they can talk through the plan for assessment and also potential treatment for withdrawal, and what to expect as far as inpatient stay for the baby once the baby's delivered. With respect to trauma-informed care, this is something that we speak about, and I mentioned earlier, with respect to these patients in particular. It's important for all of us to understand a bit about the neurobiology of trauma, understand the signs and symptoms of trauma for these patients and families. Many of these patients have been the victims of sexual violence, physical violence in the past, and that's part of the reason why the 4Ps plus or the 5Ps and screening for domestic violence, sexual violence is an important piece of using when you're adopting your screening tool for opioid use disorder. Expanding it to include a history of domestic violence it can be a very powerful tool, because it may be that was the impetus for their seeking some type of analgesia to treat that physical as well as psychological pain. And also very important for our office systems, our hospital systems, to avoid and prevent re-traumatization, that avoiding the language and the negative language and the lack of supportive care that Dr. Gary mentioned earlier, that the office and the labor and delivery experience can actually be a re-traumatization if not handled appropriately. So avoiding re-traumatization of these patients is tremendously important. I'm going to hand things back over to Dr. Gary as we advance to becoming a medication-assisted treatment provider.
So becoming a medication-assisted treatment provider. So first, I am a provider. I went through the training and have been taking care of women in pregnancy for almost 2.5 years. There is the Drug Treatment Addiction and Treatment Act, the DATA 2000, allowed for this waiver for buprenorphine dispensing, and physicians, nurse practitioners, and physician assistants are all qualified to take this training. Training is available. You can go to the SAMHSA website. ACOG District 2 is planning a training sometime in the near future, and there are other statewide sponsored training that is available if you look on the Department of Health for New York State. Next slide. So in just comparing, when you look at methadone or buprenorphine, our two mainstay treatments for opioid use in pregnancy, methadone may have better retention. There's no risk of precipitating withdrawal because buprenorphine is an agonist as well as an antagonist, so there can be some withdrawal if you start the medication too early. and that with methadone that the initiation is a little bit easier. The buprenorphine, on the other hand, it's becoming more clear that the babies have less severe NAS. Buprenorphine has less drug interactions than methadone does. It's handled in an outpatient setting instead of a methadone clinic, and therefore some stigma is reduced, and you're going to an office of maybe your prenatal care provider instead of going to the methadone clinic. And then there's, because buprenorphine is both an agonist and antagonist, there's a lower risk of overdose with this medication. So looking at office-based pain management or practice-based pain management, each hospital and office and provider really should have some sort of what am I doing about pain control, how am I taking care of pain, understanding that patients with opioid use disorder have a heightened pain sensitivity, meaning they will need some more medication initially to manage pain compared to a non-opioid use disorder patient. But you also want to withdraw or take away that medication in a relatively short amount of time. But how we take care of patients and confirm what they've been taking, what medications have actually been prescribed, we use the statewide, what in New York is called the iStop, to log on to the website and look at what the patient has been prescribed. We want to make sure we verify doses of medications when the patient is admitted to the hospital, and that we maintain medication through labor and or the cesarean process and the postpartum period, and not to simply take away either methadone or buprenorphine. Next slide. So coordinating care, as I mentioned earlier, and Dr. Kaufman also mentioned, coordinating care is extremely important, not just with the obstetrician, the pediatricians, but if the medication-assisted treatment provider is outside the hospital, to make sure that you contact them, to engage the pediatricians in the community that are taking care of these babies. Emergency medicine physicians need to understand what goes on with opioid use disorder in pregnant women. Depending on what is set up at each hospital, they may be the first line of care for these patients who come in. And they need to understand what does it mean for pregnant women, and how do we follow an algorithm so we're not creating a problem. And lastly, that you need to make sure that your discharge at each facility has some sort of standardization as well as education, so that the patients understand, okay, if we are going to limit the amount of opioid prescription. If you need more, you're going to have to contact your provider and refill the prescription because we're not going to say you don't have pain. And so those are important things. Establishing coordination of care to ensure that the treatment programs meet your family resources. In other words, do you need transportation? Do you need home visitation? What housing services may be needed? So things that are outside necessarily the realm of medicine, but more in the environmental care and or psychological care of these patients is very important, and that you must maintain some sort of communication and understand what is available in your area. So the Child Abuse Prevention Act, the CAPTA, is important to understand in your state and know what your guidelines are, know what your hospital policy is for testing and performing various, say, toxicology, and what will Child Protective Services, when will they get involved, and what is the expected length of stay. Those are all things that need to be sort of both you need to understand as the providers, and the patient needs to understand as the patient, so that you're meeting their expectations and making sure that they understand, so they're not surprised with what goes on. Pregnant women do have priority into various programs and into, say, inpatient therapies. If they need inpatient therapy, they do have priority. If in methadone clinics, they have priority. So that is important to remember. And that oops, sorry, and that treatment services, you need to understand what is available and how you can help these patients from, from returning to unhealthy behavior. Next slide. So screening all women is important, and it's important because it's the best way to identify opioid use disorder. You're also going to find some comorbidities, such as psychological and or physical or sexual violence history when you screen patients. But as obstetricians and midwives and nurse practitioners and all prenatal care providers, no matter where you are, if you're taking care of pregnant women, you're good at screening, because we do screen for HIV, we screen for hepatitis, we screen for sexually transmitted diseases. So it's not unusual for us to do any kind of screening. So you just need to simply adopt a screening process into your office and into your hospital as on admission. Next slide. So what are the tools, or what is available as a screening tool? And there are various approaches to it. There's something called the 4 Ps. Also, in addition to that, is the 5 Ps. Audit C, the NIDA Quick Screen, or CRAFT. So all these acronyms are available for screening patients with respect to substance use disorder and some various forms of psychological issues. But it's important to find a tool that's non-judgmental, open-ended, and put it into your practice and utilize it on a regular basis. And of course, we now all have electronic medical records, so it has to somehow be part of the electronic medical record. When you look at one way so we have screening, and when somebody screens positive, or even if they screen negative, it's an opportunity to provide some education. So if somebody screens negative, you can simply provide them with information. But if they screen positive, now you have to look at possible brief intervention. And what is a brief intervention? Well, it's sort of offering some non-judgmental feedback, trying to listen to what they are saying to you, understand what their motivations may be, trying to decide what their readiness is for change, and exploring other options as to where they want to go with this. So that can be done either in a written handout, which is probably the best way, and or some sort of verbal communication back and forth or conversation. Next slide. Referral for treatment are those patients who have readiness to change, and that referral could be to your own practice if you're a provider that is taken care of, as Dr. Kaufman put into the algorithm before. You have sort of some different models, and you just have to decide what model you are. And if your practice is taking care of these patients, then you're going to refer to yourself. If patient needs some excessive help and may not be able to do it as an outpatient, that inpatient, you should have some identified areas that you can refer a patient for inpatient management if necessary. And lastly, if your practice is not going to handle these type of patients, then you just need to have a way to communicate with another provider that is providing the MAT, and communicating to them and having the patient seen by them. Next slide. Sorry about that. This is Dr. Kaufman now.
So with respect to the hospital approach, we've mentioned really throughout the presentation that this is really going to take a team. So we've talked about your offices on the outpatient side having to, and your practices, everyone needing to be in support and having a shared mental model with respect to the importance of screening, and with respect to the next steps beyond screening and supporting these families and supporting these patients. The hospital is no different. We're going to have to make sure that all healthcare providers are involved in the care of these patients, that your hospital adopts a shared system and a uniform system for all of these patients with respect to the social work referrals, with respect to which patients, Dr. Gary mentioned, which patients are referred for Child Protective Services consultation. That may not be universal from hospital to hospital within your state. So deciding which characteristics in your institution are, I would say universally, these patients would have a social work referral, but which patients are referred for Child Protective Services evaluation. The teams that really need to be involved here are nursing. It's really all of the providers that would see the patient, but social work, the women's health care provider, including your OBGYN, the midwife, if it's hospitalist, you may have medical students, nursing students, residents. Everyone really needs to be on board in being supportive and understanding. The anesthesiologist, neonatologist, behavioral health specialist, and I'll get into in a moment why it's so very important to engage your anesthesiologist as well. And the emergency department. These patients may report to the emergency department. Part of their withdrawal management may be initially through the emergency department, and part of your treatment, you may initially start their medication-assisted treatment through utilization of your hospitalist team or your emergency department providers. So those are team members that you can engage as part of your referral to treatment. With respect to pain management, as I mentioned, anesthesia. The anesthesiologist and the anesthesia team really need to be on board with management of these patients, and your nursing team really needs to be on board with management of these patients. When they come into the hospital, Dr. Gary mentioned before that they'll have increased pain sensitivity. You may have increased pain requirements for their intrapartum pain when you're using pain medication throughout labor. Your dosing may be higher, and your entire team needs to be comfortable with the higher pain sensitivity that they'll have. They may need earlier pain intervention treatment, and they may need higher doses of pain medications. You want to avoid the mixed agonist-antagonist opioid analgesics. As mentioned earlier, you want to make sure, and one tremendously important piece for these patients, you want to make sure that you're continuing their medication-assisted treatment medication throughout labor. This is not something that you want to decrease upon admission. Just as for a patient who's admitted for preeclampsia, you would not stop their chronic treatment if they're on labetalol chronically for chronic hypertension. If they come in hypertensive crisis with superimposed preeclampsia, you're going to continue their chronic therapy and add additional medication on top of that. It's the same thing with the medication-assisted treatment. You're going to continue their buprenorphine, continue their methadone throughout labor or induction process, which can be very prolonged, as we all know, and then add the pain medication additionally. There are withdrawal order sets for these patients. These are, again, suggested. These are not a strict algorithm, but these are also in the slide set, slide 79, that are available to you as well. And these are slide sets that are available to be shared with your anesthesia team, your neonatologist, and your OBs as far as medications that you can use for patients that come in active withdrawal. Because you will likely see these patients, and likely are seeing these patients actively withdrawing as well. For the pain management, you have to make sure that you're continuing their medical care throughout pregnancy, realizing that the pregnancy may alter their presentation for their medical conditions, and then for the hospital team, realizing having a clear plan with respect to how you're going to care for these patients, whether or not you're continuing the medication-assisted treatment, and having a clear plan for management of these patients, a clear map for these patients will be an important part of their inpatient hospital care. Next slide. Intrapartum treatment, I mentioned briefly that their medication-assisted therapy needs to be continued. I just want to highlight that, underline that again, that it needs to be continued. We frequently see and hear that it's discontinued upon admission to the hospital, that it's thought that the pain medication that's given should be sufficient, and that you don't need to continue the medication-assisted therapy. You have to be very careful if that's done, because you can actually precipitate withdrawal within labor. The additional piece to that is you can't assume that their medication-assisted treatment is sufficient for intrapartum analgesia. I've heard many times in managing these patients intrapartum that, well, I don't really know that she needs pain medication at this point, or I think it's a little early for her epidural. I just gave her buprenorphine. I just gave her methadone. Why don't we wait and see whether or not that works? Those are apples and oranges when I hear that, that she needs her medication-assisted treatment, but that's, again, her maintenance medication, just like that hypertensive and her labetalol. And if so she's got a high blood pressure now, I'm going to go ahead and give her an IV push of medication. If she has a real spike in her pain right now and needs that epidural or needs IV pain medication, I'm going to give her morphine for her pain medication. It has nothing to do with her medication-assisted treatment. The doses for the medication-assisted therapy should not be adjusted intrapartum. You're going to continue her baseline treatment. Realize that IV access might be difficult, more difficult for these patients. So getting early access, again, engaging your anesthesia team will be really important because they can assist with IV access, but these patients can have difficult IV access. We also frequently hear that neuroaxial anesthesia is not safe, and that their teams are not comfortable with giving epidurals and spinals, and this is also untrue, that it is quite safe. You can see hypotension, so you want to be careful with respect to appropriate prehydration, but it is quite safe, and again, avoidance of mixed agonist-antagonist. For postpartum pain, again, engaging your anesthesia team will be very important, but making sure that you're giving them adequate pain medication. For vaginal deliveries, I will have, I'll engage the patient discussing with her. You have to make sure that you're doing appropriate assessment as to where she is with her pain, making sure that she's taking a baseline analgesic to help for her cramping discomfort, frequently Motrin around the clock, as opposed to waiting for that very heightened pain and discomfort. Again, these patients may have higher pain needs, but trying to avoid opioids for the vaginal delivery is often that's adequate. For C-sections, they are going to have more pain. They're going to have higher pain needs, higher opioid doses. So trying to avoid opioids, if you can, for these patients may be helpful. Trying to use non-pharmacologic treatments such as heat, such as Toradol can be helpful. If many anesthesia teams will do tab blocks, and these can actually tremendously decrease the pain needs, the opioid needs for these patients, and as can having the patients initially utilize a PCA and then early ambulation using abdominal binders. Again, those non-pharmacologic tools can be very helpful for these patients. With respect to breastfeeding, that also can be helpful for getting the patient more mobile, and we want to make sure that we're encouraging patients, if they're stable on their dose of methadone or buprenorphine, and have no other contraindications that we're encouraging them to breastfeed. With respect to withdrawal, having a tool for identification of withdrawal is also an additional piece that you need to have in your institution. The COW scores, Dr. Gary mentioned earlier that this will be built into your electronic medical record, but having the nursing team, having your residents well-versed in utilization of the COW score and comfortable with utilization of the tool. There are also links and additional tools for you to build this into your EMR in the appendix mentioned, slide 84 there, so you can see examples of how to bring this in so that you can be comfortable with utilization of the clinical opioid withdrawal scale, being comfortable with utilization as a lockdown for a respiratory depression. But there are additional medications that you can use for patients with symptomatic withdrawal, and there are additional tools listed there that are in some of the appendix materials for, depending on the patient's symptoms, use of clonidine, antihistamine, benzodiazepines, depending on where the patient scores for her COW scores. Those medications can be safely utilized for the patient's withdrawal symptoms. And as OBGYNs, we can manage many of their symptoms as they're withdrawing and then treating them with a medication-assisted treatment. If uncomfortable, these patients may be co-managed as well with an addiction medicine physician, or if not available, the hospitalist may be able to assist as well. I'm going to hand things back over to Dr. Gary for treatment services.
So identifying those treatment services and facilities that are available in the area is important. Patients often have polysubstance use and may include alcohol and or other drugs, and certainly have some underlying psychological issues that you may need behavioral health services. So it's important to identify what's available in your own communities. Here, where I am in Eastern Long Island, it took me a while to sort of identify various areas that are close to where patients live, that the services can be provided. So, but it is important to identify that. With respect to, with respect to universal screening, make sure you have the resources available in your office. And if you need help with finding some treatment, so both OASIS for New York State and SAMHSA also have provider referrals available. And if you, in the appendix of this, we have some of the information available to contact both OASIS and SAMHSA. Next slide. So in conclusion, screening for substance use should be part of your comprehensive obstetric care. And that should be done optimally on the first prenatal visit, and in sort of a partnership with your patient. That you need to utilize language that helps reduce stigma and reflects and promotes evidence-based treatment and respect for our women. It's important that prenatal, intrapartum, and postpartum clinical pathways for women with opioid use disorder incorporate the coordination of care among the various providers, from both clerical staff, nursing, social work, physicians, and even the other ancillary staff that support both our offices and labor and delivery and maternity services. So it's important to involve all of them. And that you should understand your personal, or not personal, but your regional area resources that exist. And this is wait, we'll turn it over to Kelly here. Hold on.
Great. Thank you both, Dr. Kaufman and Dr. Gary. Great presentation today. This is just a list of the many task force providers who developed this educational content under the guidance of Dr. Kaufman and Dr. Gary. And this page just offers the link to where you can find the education, which is on the ACOG District 2 website. As Dr. Gary and Dr. Kaufman mentioned, the full bundle can be accessed through the website, and we will include a link to that education within an email that we'll be sending out after this webinar. So we do have some time to entertain some questions. If folks had any questions, please submit those through the chat feature, and we can facilitate those. Just a few items of note while folks are getting any questions you have into the chat. After this webinar, we will be sending out an email with a link to a post test. Please follow the instructions within that email for obtaining your CME certificate and credits. That link and post test will be available up to 1 week from today so that you can obtain your credits. And then just a few notes on some upcoming activities. As Dr. Gary had mentioned, we will be hosting the American Society of Addiction Medicine buprenorphine waiver training specifically geared towards women's healthcare providers this June in the city. So be on the lookout for more details on that offering. We also have our nearly finalized second bundle in this series, focusing on response and reporting and focusing heavily on addressing pain management, care coordination, women-centered treatment, and linkages to services. And our hope is that that bundle will be released in the coming months. And then finally, District 2, in partnership with New York State OASIS, had created recently an expert provider education video, specifically addressing OUD and pregnancy. And this video provides an example of a patient encounter emphasizing implementing ESPER as an effective approach to care, and that video should be available on the District 2 website in the coming weeks for everyone. Don't see that we have any questions currently. Just give folks another minute. Okay, so we do have a question. What fetal surveillance is recommended for our patients who are on MAT during pregnancy? Dr. Gary or Dr. Kaufman?
Sure. So this is a discussion back and forth from various providers who deal with patients with opioid use disorder. We certainly follow them as anybody, early pregnancy with a dating ultrasound. Typically we follow the anatomy scan, and then we will follow them periodically every about 4 to 6 weeks, looking at growth scans, because the opioid use disorder has been associated with growth restriction. So we will follow growth, and typically from 34 weeks on, we utilize weekly fetal testing, the biophysical and/or an NST included with the biophysical.
I would say that that's consistent with what we're doing locally at SUNY Upstate. One of the things that you want to consider when you're doing the BPPs, and we do them weekly after 34 weeks as well, but consider the timing of her medication-assisted treatment and realize that you will get non-reactive testing. Generally, if she's just taken her dose, and that's something that you do have to consider the timing of the dose with respect to the time of the biophysical profile. We have a lot of patients that are then transferred to labor and delivery for prolonged monitoring, and then have associated stays that the fetal evaluation ends up being reassuring. The patient's discharged home, but just something to consider as you're doing that evaluation.
Thank you. We have another question. For our home visiting service, we would use this information to support parents we work with living in recovery or with OUD in pregnancy, and maybe as a tool to promote self-advocacy as well. Does this seem in step with, or is that in step with this information?
I would say absolutely, and getting that information to them as early in the pregnancy as possible is tremendously empowering and useful, and improves the safety for mom. Breaks, if we're talking about getting them into treatment for medication-assisted treatment. It breaks the withdrawal treatment cycle and gets them into a maintenance therapy. For baby, getting them into treatment reduces the risk of the neonatal abstinence syndrome. So if we're talking about getting them information about what screening tool is used at the hospital, it gives us the possibility of setting up that visit with the neonatologist. It gets them, the earlier that we can get those tools in their hands, the more support you can provide for the family and for the patient.
Thank you. That's all we have as far as questions submitted. If anyone does have any questions that come up afterwards, please feel free to reach out. We'll be happy to facilitate getting a response back to you. And again, just look for that link to obtain the post-test and the CME information for today's webinar. Thank you both to Dr. Gary and Dr. Kaufman for your great presentation today, and to our attendees for joining us. Have a great weekend.